thank you so much for your very kind introduction. I would also like to start by acknowledging the traditional custodians of the land we meet, the Whadjuk people from the Noongar Nation, and pay our respects to their elders past, present, and emerging. It's a real privilege to be here today and talk about the work of the Dobney Hypertension Center. And usually you don't start with a slide where you thank people for what they've done, but Laurie beautifully already summarized that the Dobney Chair in Clinical Research is really a collaborative venture between three major stakeholders: the Royal Perth Hospital here, represented by Arish Anwar, the University of Western Australia, and it's great to see Anna Novak here today, at the time represented by Brendan McQuillan, and of course Laurie Balin, and he played a very critical role in convincing me to come to Western Australia, into a very thriving, into a very stimulating environment. And hopefully I can showcase a bit that I think we have achieved some, not everything we wanted, but critical aspects in terms of community health in the first place, but then also in terms of impact of the research that we can do. And as you would know, if you're applying for grants these days, it's all about impact on the community, on the people affected by various conditions. So I think it's a critical aspect. Laurie beautifully also summarized already how critical it is to have an excellent team and be able to maintain and grow that team. And this is why I brought this image up. This is not everybody in our lab, but over the years, critical people, a clinical team. And I would like to mention Anu Joyson here, Darren Brockman, Justine Chan, and a lot of the doctors there in the background. Revathi Khan Nagarin, who's now doing her work at Geraldton for the moment, moving more into rural health. But I also pride myself, or ourselves, very much with the fact that we are very translational. We have a number of fabulous basic scientists, or I call them translational scientists, Dr. Vance Matthews and Dr. Lakshmi Herod, who run our experimental cell culture, tissue, and animal work. And the beauty of our lab, I believe, is that translational aspect, which I think we truly cover, and that hopefully helps us to move forward with more exciting research. So I have the Dobney Chair in Clinical Research, but we called our center, after we talked to the Dobney family, the Dobney Hypertension Center. Hypertension meaning elevated blood pressure, and this is the cause or the core of our research. And why is that? Well, just to put it into perspective, to apply a global lens, elevated blood pressure is the biggest killer worldwide. Close to 11 million deaths every year are directly attributable to uncontrolled blood pressure. That ranks way before these other risk factors, and that doesn't mean, of course, that we wouldn't want to target all of them. But the biggest impact for your intervention you usually get when you lower blood pressure. If we apply a national lens in Australia, more than 25,000 people die every year directly due to uncontrolled blood pressure. So these are staggering numbers, and we have to try to improve what we're doing to control it. Why is hypertension such a big killer? Well, hypertension means increased blood pressure within the vasculature. And that not only puts strain on the blood vessels themselves, but onto all the organs that are being perfused from that central aorta, in particular the brain, the heart, and the kidneys. And you see a number of conditions, all of which are very closely associated with high blood pressure. The worst in my mind are strokes, and hypertension is the biggest, most important modifiable risk factor for strokes, but also heart attacks, heart failure, cognitive decline, dementia, vascular dementia in particular. I'm a kidney doctor, and unfortunately we see quite a lot of people who need replacement therapy through dialysis or transplantation. unfortunately reaching that stage of end-stage renal disease because they had either hypertension or diabetes, which are the most common causes, and a whole range of other aspects that are clearly critical. We also know if we manage to lower blood pressure, that we get dramatic benefit. This is data from a large meta-regression analysis, meaning you pool all the data that is essentially available to get a bit of an idea about the magnitude of the effect of lowering blood pressure. And if you have heard or if you know your numbers, which you hopefully do, it has been shown that if you manage your blood pressure by 10 points, 10 millimeters of mercury as we relate to it, you can reduce your relative risk for cardiovascular events by 20%. This is massive. And given the close association with strokes, you see that particularly in the context of reduction of strokes as well as heart failure, lowering blood pressure is probably the most effective health intervention we can apply to improve outcomes or reduce the event rates in our patients. Now, going back to a national lens, how are we trailing in Australia? I must say very poorly. This is a relatively recent publication which compared the control rates of blood pressure, meaning that the blood pressure is treated either with lifestyle or pharmacotherapy medication, and how many of those who have been identified actually achieve the required control. And as you see on this slide, we do very poorly compared to a lot of similar countries such as the US, Canada, New Zealand. Only 32% of those with high blood pressure are controlled, meaning 68% are left at unnecessary high risk for strokes, heart attacks, heart failure, and kidney disease, and this is massive. And obviously, what is required here is better implementation of the impactful therapies we already have. Make sure people take their medication, make sure they adhere to a healthy lifestyle, and many more. Work with our doctors, general practitioners, to avoid physician inertia, meaning that they see the blood pressure but they don't act upon it and increase the medication. And this is where I, as the president of Hypertension Australia, together with an excellent colleague from Sydney, Professor Alta Skutte, who is on the Australian Cardiovascular Alliance, we formed a national hypertension task force. We made sure we have all the relevant stakeholders on board: primary care, the learned societies, cardiac society, renal society, and essentially all the relevant stakeholders. And in December 2022, we launched this national task force, which was done by the Health Minister, Mark Butler, on the 8th of December, with the remit to increase control rates from currently 32 to 70% by 2030. Now, this is a very ambitious goal, but we have excellent support from colleagues in Canada and the US who've done actually relatively well in improving control rates. So this is what we do kind of on a community national level, but I'm sure you're also very interested in hearing what we're actually doing locally, and this goes more into the type of research we do. And Lynn already mentioned that we have a specific interest in the so-called sympathetic nervous system. So these nerves, they innervate virtually every organ in the human body, and particularly organs that play a critical role in cardiovascular control, blood pressure, heart function, kidney function. And if there's an increase in the activity of these nerves, usually generated in certain brain stem areas, you get, for example, in the regards to the kidney, three effects, all of which will raise blood pressure. So wouldn't it make sense to try to inhibit that trafficking, reduce that traffic in order to improve, reduce sympathetic activity and therefore reduce blood pressure? And obviously you need some means of measuring the activity, which is actually very difficult, and we have very unique methodology called microneurography, indicated here, where we place a very fine electrode into a superficial nerve which links the brain and the periphery, and we can online monitor sympathetic nerve activity, and we can see whether certain interventions help to reduce that activity. And we have provided data over the last decade to show that these kidney nerves are particularly important, and we thought, well, let's try to inhibit the trafficking there. And with modern technology that is possible, catheter-based interventions now allow us to actually place a plastic tube into the kidney artery, and the nerves are surrounding these arteries, and by placing this catheter, which is capable of emitting a certain type of energy into the surrounding tissue, we silence these nerves and therefore lower blood pressure significantly. These are two of the devices we worked with. In fact, we just did a case on Wednesday this week and have some almost every week. And guess what? This is now in European guidelines as another tool option to reduce blood pressure. Once you made it into guidelines, you know this works, it's safe and it's effective, and that's a beautiful kind of, not the end, but a milestone in terms of establishing this therapy, which is very new in the space. So rather than just lifestyle and pharmacotherapy with medication, we now have interventions. And we work on a number of very exciting other developments. The sympathetic nerves lend themselves to modulation through different approaches, for example, in the carotid body or in other aspects of the brain. And we can target that by targeting neuroinflammation with certain drugs. So this is kind of our vision for the next 5 years, quite intense and a bit too much detail here. But we continue also to work on medication, and there has been enormous advances in the treatment, not only of hypertension, but particularly also diabetes. And diabetes drug class called SGLT2 inhibitors have been shown not only to improve glucose control, but in fact to protect the kidneys and the heart. And it was unclear how does that happen, how does that work. And in fact, Lakshmi and Vance have really identified that one way this occurs is by inhibiting again this sympathetic nerve activity, and they've done wonderful animal experiments to showcase that, and we have replicated that in humans. We've just published a very important study, a novel treatment for people who are so-called resistant to conventional therapy. So essentially we throw everything at them we have, blood pressure doesn't come down. This is a new drug class called endothelin antagonists, and you see here compared to the blue placebo, a clear-cut reduction. So this is currently being looked at by the Food and Drug Administration, will very likely be approved and available to our patients tomorrow. Today's research is tomorrow's treatment, the motto we have on the top of the building, and I think we are really taking that at heart. Obviously, this is not possible without significant collaboration and partners, and these are just some of them, and there's so much more to do. So I'm extremely grateful for all the support. We're extremely excited. There's so much to do, and we need all hands on deck, essentially. And with that, I thank you for your attention. Thank you very much.